Okay, hello everyone. It is a concerned doctor, and it's March 1st, 2021, coming up on the anniversary of COVID-19. It's been a while since I did a podcast. Unfortunately, in September and October, I had to have eye surgery, and fortunately, that's coming along nicely. So I took a break from the podcast, but I'd like to do some updates today, this evening, and go through kind of what we've learned in the last year, since we are coming up on a year since the first patient that I treated, at least in the hospital, that I knew of COVID-19. And I think probably took care of a couple patients that I wasn't even aware had COVID-19, probably in December or January. But the official anniversary of the first patient I officially treated is coming up in a couple weeks. So I'm going to do some screen sharing because I'd like to go over some of the outpatient and inpatient concepts, but focus mostly on the inpatient right now. What are we doing differently today than we were doing a year ago? A year ago, we were told don't use aspirin, don't use steroids. Certainly, inhaled steroids we weren't using because the concern of sort of spreading COVID around the room with the nebulizers. And where are we with the data and the publications in regards to these therapies? Well, the British study that came out, I think it was probably around May or June, I forget exactly, but right overnight we were using dexamethasone or Decadron, an old steroid. In Europe, it's used frequently. In the United States, we tend to use methylprednisolone or solumedrol in an IV form in hospitalized patients, at least historically, even prior to COVID, for exacerbations of asthma, COPD, or other rheumatology and other conditions, steroid responsive process. And they were converted to prednisone historically. That's what we did, and those are the drugs that we believe have the best absorptions and maybe block the best inflammatory markers. But Dex or dexamethasone became an overnight use in the United States for COVID-19 when that publication came out and showed a mortality benefit in patients that were hospitalized and received Dex. Whether or not to give it to the outpatient was sort of thought, if the patients were hypoxic, if their pulse oxes were hitting 94% or 92%, which really isn't that hard to do. And I've treated most of my outpatients with pulse oximetry and even supplemental oxygen at home. The minus of treating them at home when they're more moderate or pushing that zone is that you don't have remdesivir. Again, pretty much every admission to the hospital still, since we've gotten remdesivir, is getting that. And you can see this study here where we're adding Baricitinib, this JAK2 inhibitor, plus Remdesivir, an antiviral. And Remdesivir, made by Gilead, is really been used on pretty much every admission with a drop in pulse oximetry. But Baricitinib, we are giving some hospitals more than others, but it's sort of that patient who comes in with inflammatory markers, what we call the C-reactive protein or interleukin 6 values that are elevated. This is a nice option as an oral agent for about 5 days. And it shortens your length of stay by about a day is all we really saw. But we also saw in some of the studies that, potentially reducing inflammation and potentially oxygen requirements and dropping down on the oxygen a little bit more. So it is a real option, especially in that patient you're concerned about giving the higher dose steroids to, or Actemra, tocilizumab, which I have some information on as well, these two studies. But Tozi or Actemra, an anti-IL-6 medication, when you have those markers that are up, is also a real option. But we did see some problems in at least those more severe COVID-19 patients where that benefit just didn't seem to be there, and may even be a risk for developing secondary infections like staph or fungus. And so you have to be cautious when using this late, especially in the more severe COVID patient, especially in the patient where you're tempted to use it to with the raised markers. Again, those CRPs and IL-6 values, maybe those patients who have the high D dimers that you're giving full dose therapeutic anticoagulation to. But if they are, 70, 80 years of old age or have comorbidities, they are at risk of getting infections. So you have to be cautious. But in that more just pneumonia patient, we did see, where is it here? Here, the less severe, potentially, the ones that maybe are on higher oxygen levels, but or BiPAPs, but maybe the ones who were not yet on ventilators, there did seem to be a benefit of giving tocilizumab. So I think this agent is best for that younger patient who has elevated markers, who are not as concerned about developing sepsis, who you're not giving maybe the pulse dose steroids. Also, we are tracking procalcitonin levels almost daily in some patients because it's a good marker and a good gauge for who needs antibiotics or who may have infections underlying besides COVID-19. So those bacterial pneumonias that you want to give antibiotics to. I've used a lot of doxycycline, both outpatient and inpatient. That's a whole other lecture. So baricitinib for that patient who you think is higher risk, oral agent, we've been using about 4 milligrams or so for 5 days in inpatients. I have not utilized it as an outpatient drug. And giving it with remdesivir because these are the patients who do have pulse oximetries that are lower. And then Actemra for the patient you're willing to take a little bit of a higher risk with an IV infusion, also with elevated markers. And again, maybe that younger patient who's less at risk, who doesn't have as many comorbidities. So higher comorbidities, maybe baricitinib, tocilizumab for the one with less comorbidities, where you're really looking to knock out that cytokine storm. A little bit confusing, and I may have mixed them up a little bit there, but the point is we have these other options. IV pulse steroids, so really whacking them with high dose solumedrol or methylprednisolone, 125 to 250 daily, or some suggest even using the Q6-hour dosing can be quite a robust regimen, and it could also induce immunosuppression and septic shock in some, put them at risk at least. But if you're really trying to knock out the cytokine storm, and maybe in those patients who the markers aren't quite as high compared to what you're using the tozi or the baricitinib, it may be something worth trying. Or you've already tried Actemra, you've already tried tocilizumab, and now you want to try pulse dose steroids. But really getting them early on with all of these regimens is the idea. Of course, you would never give high doses or these medications to mild outpatients or patients who are very mild that are admitted to the hospital. We are giving dexamethasone again if your pulse ox gets down there around 94, 92%. Giving lower doses of dexamethasone. I think we're gonna kind of regress back to using prednisone and methylprednisolone, so oral and IV, what we're more used to using after COVID's been around for a year or two longer. I just don't, just because the British study showed Dex saved lives doesn't mean that solumedrol or methylprednisolone or prednisone doesn't either. And we have a bigger comfort level with using these historically. So what dose you use is really the trick, probably rather than which one, but who knows, maybe we'll find that methylprednisolone or the glucocorticoid base rather than the mineral base, more like Dex, is actually better. And I am not reluctant to use this upfront over dexamethasone, especially if you have a COPD or asthmatic patient that's having an exacerbation along with the COVID-19. So, you could spend an hour on each one of these regimens just going over it. The frontline COVID-19 critical care recommendations are out there as well. I don't use them as a Bible or gospel protocol, but I do use certain things in this regimen because there is some data supporting it, or at least data supporting its use in other viral infections. Historically, is probably more true. The one that's gotten the most attention is ivermectin. Merck has come out and said that they see no benefit to using it. However, you do see studies that are published. Unfortunately, most of them are not published in peer-reviewed articles. And once they go into journals, excuse me, that are peer-reviewed, they'll gain more traction. And the more traction they'll gain is going to be based off of whether these are randomized placebo-controlled trials, which this is not. This is more observational, if you will, but there was a significantly lower mortality noted in the Chest Journal that was published. So this looked at ivermectin versus those who got it versus those who did not, and chart reviews out of Broward County in Florida. And there was, in fact, benefits noted for in-hospital mortality. And this gets a lot of attention, and a lot of patients will ask about it. Unfortunately, when we get asked about it, most of the time, they've already progressed past, the FiO2 or 50% oxygen or the BiPAPs, and they're already on invasive ventilation. And once they're that severe, we're really kicking back to the steroid, Baricitinib, tocilizumab story rather than salvaging with ivermectin, which is historically a worm drug. And as some have told me, it's a great worm drug, but we need more peer-reviewed journals like this, articles, but we need them with placebo-controlled, published, and that'll gain more traction. With that said, ivermectin is quite safe. Very few people are at risk of having side effects from it. What dose to use is debatable. Most are using it for up to 5 days or a scattered, day 1, day 3. But there may be some utility. It just needs more traction. So anyway, in the let's see here, the outpatient protocol, they're using a 0.2 mg per kilo dosing. Some are winging this and just saying, in females, maybe giving somewhere around 4 or 5 pills, or in males, similar, a little bit more, but you can go with a weight-based. I've personally used doxycycline, which I don't see listed here, in the earlier outpatient COVIDs as well. And then, the vitamin D, C story and zinc. If honestly, I think if this is going to help, it really is in the prophylaxis stage, trying to salvage, or once they're already admitted with moderate to severe COVID and giving it. We've tried that game and it just doesn't seem to work. Although the vitamin C that we're using in most hospital systems, I think, is probably on the lower scale like this, or even lower at 500 milligrams a day. And probably you're not going to have much benefit if you're using it like that. And you'd have to get approval to use it at 6, 12, 24, or even higher milligrams a day. So we're talking 24,000 milligrams in a day, something like that, or at least 10 to 12,000 a day. So these are big doses, which most hospital formularies aren't going to support, because you'd have to order a lot of it just to keep up with it. And until there's, again, peer-reviewed publications in big journals, that won't gain the big traction. Quercetin, another antioxidant. I've got a bottle of the 500. I don't take it daily, but prophylactically, it may have some benefit, sort of like a vitamin C benefit. And some people believe in N-acetylcysteine, bromelain from pineapple root, and all this. And my thing is that some of this stuff may have anti-inflammatory or antioxidant benefit, but your body can only process so many medications at once. If you overload it, it could be a problem too. So this is all with caution. The story with zinc early on, and with treatment, antiviral replication, maybe it helps. Be careful of chelation and getting copper deficiency if you go above 50 mg per day. And melatonin, anti-inflammatory, potentially. Probably don't need all that much, but there's people that quote doses all the way up to 10, 20, 50. So you have to be cautious probably when you get into super high doses. And there's mixed belief on that, but this is a reasonable outpatient prophylactic regimen that looks overall safe, but there's always caveats to that. And people that are born with rare deficiencies and stuff that can't metabolize things. So always be cautious and check with your primary cares. If they're already sick, hitting them up with the extra aspirin, and of course having a pulse oximeter available can be helpful for guiding patients to the ER once the pulse ox becomes concerning, to get at least labs. And I've utilized lab services at home to even get D-dimer levels and help me guide them to the ER for CT angiograms or to rule out clots. So I'm not standing behind everything in here, but I do pick from it and utilize peer-reviewed articles along with these protocols in combination. So if you're in the hospital already, instead of Dex, the Math Plus protocol recommends methylprednisolone and going up to stress doses as high as 250 Q6 with caution. Ascorbic acid, this is even light if you look at some of the protocols out of China and Italy, where they got up to, I think in some cases, 25, 50 grams of this stuff a day. And thiamine, some people believe can add some benefit as well, either outpatient or inpatient. Of course, the heparin story, whether to go therapeutic or prophylactic, a whole lecture in itself that we've done before. We've actually done lectures on all of these for the most part. I've never gotten into a separate lecture on Lipitor or atorvastatin, but maybe having some benefit as well. And most of this stuff is repetitive. Pepsid, we've talked about that in separate vlogs versus protonics and benefits. A little bit of caution in the super elderly or those with dementia or neurologic dysfunction, but for the most part, Pepsid is safe stuff and easily peed out. And of course, plasma transfusion and exchange. And Grifols working on hyperimmune globulins and all these different types of options with mixed review, but nothing that's been, oh my God, we have to use this on every patient that's admitted. We went through that phase, and I think we anecdotally saw mixed use with plasma, so that sometimes you get a demand from a family, I need them to have a plasma exchange or have plasma, and in this protocol they recommend every other day, but there's very little data to support that type of recommendation. With that said, if patient is progressing, you want to use this in the first 72 hours if you can. So if they come in pretty sick and it's within early admission time, it is worth a consideration. And certainly, I don't personally turn down people that request it, but with a caveat that we saw mixed anecdotal outcomes. So I think that's enough for revlogging tonight. There'll be more to come, but we have gotten better. In conclusion, it's been a year, and where we were not using steroids and aspirin therapies early, now you see them sort of regularly used, or some form of anticoagulation with steroid, what dose you use and how you pulse it at them at high doses if it's concerning that they're progressing to higher flows of oxygen. But being able to finesse early use with not overuse in people that you don't want to suppress the immune system is really the tricky part. But knowing that we have baricitinib, knowing that we have tocilizumab, that we've learned how to use them better, I believe, and finesse their use, as I said, depending on the markers that we're checking, depending on their comorbidities, and depending on the sequence of events of when symptoms really occurred first. I'll do other vlogs on vaccine and how we are seeing patients admitted who have gotten one or two of the vaccines, but usually it's early, right after getting the vaccine, if that's going to happen. And in fact, most of the outcomes have been quite good. So numbers continue to drop on admissions with COVID. Good news. I do believe that is a direct result of the vaccine. Plus, a lot of people have had COVID. And I think that we'll hear stories of providers and others in the public that have received vaccines that went for antibody testing, and they'll find that not only is their IgG elevated, but potentially even more acute antibodies like IgM, and we'll have more on that as time goes on. Everybody have a great night, and thanks for joining, and we'll do more vlogs in the near future.